Hey everyone, this is Whitney. I will be going over with you all my research project titled Femoroacetabular Impingement, Non-Surgical Approach to Stay in the Game. Femoral acetabular impingement, FAI definition, it is when the ball and socket motion of the hip joint becomes impaired by a bony deformity or pathomechanical process causing microtrauma to surrounding bone or articular cartilage within the acetabulum. There are two different types of FAI impingement. That would be a cam impingement or a pincer impingement. Cam impingement occurs when a bony abnormal growth is on the femoral neck and the head, whereas a pincer occurs as a bony growth on the rim of the acetabulum. The prevalence of FAI tends to occur more so in the athletic population more than the general population, and the movements that have research seen that cause FAI, especially in younger growing individuals such as athletes, are repetitive motions that include cutting, changes in direction quickly, overly extending hip flexion, and internal rotation of the hip. The sports most closely associated with these motions are soccer, dancing, and ice hockey. As far as diagnostic tools, obviously examination is the first line of approach in determining what is wrong, followed by the signs and symptoms. Individuals with FAI typically complain of the signs and symptoms of pain in the anterior posterior hip, insidious groin or thigh pain that occurs, as well as weakness in surrounding muscles, a lack or limited of range of motion, specifically with hip internal rotation and extension, as well as hip external rotation and flexion. If you have anybody that is experiencing these issues, they should be referred for imaging. That will probably most likely be an x-ray. If an x-ray does not show anything, then the next step would be an MRI, and then after that would be the golden standard of the MRI with gadolinium, or otherwise known as contrast. And the contrast will show if there are any leakages in the hip joint, which would then be indicative of a tear, probably from a bony prominence to the articular cartilage. As far as secondary complications, joint damage from the bony prominences, as I said before, can cause a tear within the articular cartilage of the acetabulum, and this is being very prevalent, even seen in athletes as young as 20s and 30s. In addition to that, it can cause early onset arthritis, which has been seen in early as athletes with FAI in their 30s and their 40s, where typically hip arthritis is not seen until much later in life. There are two main interventions for FAI, the arthroscopic surgery and the non-surgical approach. As far as recovery length, arthroscopically, it's going to be at least 16 weeks until an athlete's able to begin impact activities. So it's a very long recovery. As far as success rates, there is about an 87% of success rate of athletes being able to return back to play, but only about 82% are going to be able to return back to the same level that they had originally been at before the surgery. However, it's very highly to note that these are mostly the success rates from professional athletes, whereas recreational athletes, it was more so seen that these individuals, if they did do the surgery, decided to stop playing, or they completely removed themselves from activity, therefore being a career-ending injury, in order to reduce hip pain and further damage within the joint. Quality of life, there are still some questions about, because arthroscopic surgery is so new. There's not been any longitudinal studies or follow-ups with patients post-surgery to see what their outcome overall ends up being. As far as non-surgical, the three options are activity modification, injection, or physical therapy, which I'll go a little bit more into further in. My scientific questions, purpose statement was the purpose of the study was to determine what non-surgical treatment protocol was effective in decreasing symptoms in athletes with femoral acetabular impingement. The research question being, what was the most effective non-surgical treatment protocol in decreasing symptoms for athletes with femoral acetabular impingement, and the null hypothesis, where there were no significant differences in effective non-surgical treatment protocols. As far as the actual study, it was a pre-test, post-test randomized group study. So the individuals were tested before and after the study. There were 3 groups. The no physical activity group, they completely removed themselves from any physical activity during the duration of the study. And the physical therapy group, they replaced their activity with 3 physical therapy sessions a week. That was all they were allowed to do. And the control group, they continued on with their same physical activity levels with no restrictions or limitations whatsoever. The individuals were giving 3 questionnaires. I'll go over a little bit more here in just a few moments. And then the length of the study was 12 weeks. I had 120 athletes with FAI that I studied. 72 were male, 48 were female, ages 18 to 34, and each individual was divided up into 3 groups randomly into groups of 40 into each group that I had just talked about. Each individual received a consent form explaining to them the study, the purpose, their ability to withdraw at any point in time, and this was approved by the Institutional Review Board. The 3 questionnaires that were used were the Harris Hip Score, the Hip Outcome Score, the Western Ontario McMaster University's Osteoarthritis Index, the WOMAC. These were patient-reported outcomes or PRO questionnaires. Each one was valid and reliable, and different ones assess different domains such as pain, disability, function, and discomfort within the hip joint. Authorization was obtained from each participant, the IRB, as well as the administrators representative of the participants if they were on any teams. The questionnaires were given to the individuals before the study began. They completed them, and then it was tallied up for the results of the pre-test. The individuals were then randomly divided into the 3 equal groups of 40 and explained the group requirements. And then after the completion of the study at 12 weeks, each individual was then given the same questionnaires once again to complete, that were then tallied, and the post-test results were compared to the pre-test. The data analysis was a repeated measures analysis of variance to test the difference between the no physical activity group, physical therapy group, and the control group. As far as results, physical therapy group showed the highest decrease in symptoms in comparison to the no physical activity group and the control group. The physical activity group also showed less pain as well as higher levels of functionality within the affected hip when compared to the other 2 groups. The no physical activity group did see some decrease within their pain, however, not very much increase in functionality. And the control group, there were no significant differences or decreases within their pain and hip function. Therefore, the hypothesis was supported that there is a non-invasive approach of being able to stay within the game for athletes through physical therapy. There's still some debate in regards to surgical versus non-surgical. Some people say that surgery is the best option, whereas there's a whole other group of researchers that are trying to push for more non-invasive research as an option for FAI individuals. Physical therapy research, it's pretty much split 50-50. Some individuals are seeing really great responses after 3 months, whereas there are other individuals that are not seeing as much results and still continue on with the surgery. And one of the largest factors that they found has been age. Typically, individuals that are older respond better to the physical therapy, whereas individuals that are younger are not responding as well. And they believe that's because younger individuals tend to be within the athletic population and are pushing their bodies more than individuals that are older and maybe less active. The severity of the FAI is a large factor, as well as other contributing factors of osteoarthritis, other hip diseases or illnesses, as well as the age of the individual. As far as recommendations, further research should be into standardizing a physical therapy protocol specific for FAI individuals to increase hip mobility, flexibility, and function, perhaps including the use of NSAIDs or steroid injections. Further research should also consider randomized controls comparing postoperative hip arthroscopic patients versus non-surgical patients to help determine the severity of FAI versus activity level versus gender and age, and to determine which option would be best for which specific type of FAI. There also is an extreme rate out there of research saying 24 to 67% of athletes actually have FAI but are asymptomatic, and individuals are wondering if treatment should be given to these patients or if maybe they should be put into a longitudinal study for further research to determine when symptoms may occur, what could have caused that change, and what we can learn to increase treatment and possibly reduce the possibility of FAI symptoms occurring. As far as application, examination and education is imperative for athletic trainers, being able to know the signs and the symptoms to look for, and with when to start rehabilitation or when to go ahead and send them straight for imaging to get that specific and concrete diagnosis. Once a diagnosis of FAI is reached, then decisions are obviously needed to be made, whether that be the surgical approach, a non-invasive approach, or even removing themselves completely from participation in sports. If they decide to go with a physical therapy approach, obviously, even though there's not a specific protocol, there are specific recommendations such as core strengthening, lower leg exercises, continuing with postural assessment and strengthening, and avoiding any type of painful motion. The biggest thing to remember is that even through surgery, it's a 4-month at least rehabilitation plan, or physical therapies at least 3 months. It's going to be a long road for the athlete as well as the athletic trainer. And so remaining positive, remaining committed, and supporting the athlete in their decision is going to be imperative in their success. In summary, closing, femoral acetabulum impingement occurs when there's an unharmonious mechanism or abnormal bony growth within the hip joint, and they are usually caused by a cam or a pincer impingement. FII typically occurs within athletic populations, which as athletic trainers is the main population of which athletic trainers work. There are a couple of different treatment options such as surgical, non-surgical, whether that be injection, activity modification, or even physical therapy. So it's important that patients know that they do have options. However, to keep in mind, there is a variability in demographics as far as level of activity, the age, if there are any pre-existing conditions that can seriously affect the treatment that would be best for them. Patient options and outcomes, it's important to know that they do have options. However, there's not a lot of research post any type of treatment, whether it be surgical or non-surgical, which is something that needs to be further explored. These are my references, and hopefully you all were able to learn something. And if you have any questions, feel free to reach out. I'd be more than happy to answer any questions you may have. Thanks. Have a good night.